Welcome to the RadOnc Smart Review Head and Neck Cancer series.
Today, we are really getting into a foundational topic, oropharynx cancer.
Absolutely. We're going to cover everything from the ground up, the H.P.V biology, the A.J.C.C 8th edition staging, and, how all of this actually shapes what we do in the clinic.
And if you're studying for boards or just starting your rotation, this is one you can't miss. Oropharynx has completely changed the landscape of head and neck oncology.
It really has. And if there's one single concept to take away today, it's this idea of duality. You have to understand that oropharynx cancer isn't one disease.
Right.
It's two completely separate, biologically distinct entities that just happen to live in the same part of the body.
That's the whole key. On one side, you have the H.P.V positive disease. That's the virally driven cancer in younger, healthier people with these incredible outcomes, often over 90% survival.
And then on the other side,
you have the traditional H.P.V negative cancer, the one we think of from heavy tobacco and alcohol use in an older population with more comorbidities and, frankly, a much worse prognosis.
And this biological gap is so huge, it literally broke the staging system.
It did.
I mean, the A.J.C.C in the 8th edition did something they'd never done before. They created two totally separate T&M staging systems. You have to know the H.P.V status to even begin to stage the patient.
And that's our mission today. We're going to unpack that split. You need to understand why a patient can walk in with a huge cystic neck node, something that would be automatic stage 4 in almost any other head and neck cancer.
Right.
And still be classified as a stage 1 H.P.V positive oropharynx. And, why that's actually the most accurate way to describe their prognosis.
Okay, let's ground this whole discussion in a real-world case. This is exactly the kind of scenario you need to be able to break down for your oral boards.
I'll do.
So our patient is a 52-year-old man. He comes into your clinic, and his only complaint is a painless left neck mass he noticed about 3 weeks ago. And here are the key details. He is a never smoker, maybe an occasional social drink, but that's it. He has none of the classic red flag symptoms. No pain, no trouble swallowing, no adenophagia, no ear pain. His weight is stable.
And that is just the poster child, isn't it? The modern oropharynx patient. The asymptomatic neck mass is the alarm bell.
It is. So on physical exam, you feel a 3-centimeter firm, mobile mass in that left level 2 region. His oral exam is really subtle. There's just a little bit of asymmetry in the left tonsil, nothing glaring. You check his jaw opening, no trismus, which is good. It means the medial pterygoid isn't involved yet. And your flexible laryngoscopy just confirms some fullness in that left tonsillar fossa. Vocal cords are moving fine.
So the suspicion is high, and the imaging is going to be what really defines the extent of this.
Exactly. So the CT of the neck with contrast comes back, and it's diagnostic. It shows a 3.2 centimeter left level 2 lymph node. And what's really important here is that the node has central necrosis,
which is highly suggestive of metastatic disease in a head and neck node.
It is. And right alongside that, you see a 1.8 centimeter enhancing mass in the left tonsil. So there's your primary.
Okay. And then you'll want an MRI to really nail down these soft tissue details for staging.
Yes. So the MRI confirms that tonsillar primary, but just as importantly, it tells you what's not involved. There's no invasion of the skull base, no pterygoid muscle involvement, and no obvious encasement of the carotid artery.
Which is huge for ruling out the really advanced T4B type disease.
Right. And then the PECT confirms what we suspect, hot uptake in the tonsil and that level 2 node. But thankfully, no distant disease, it's M0.
And the final piece of the puzzle is the biopsy.
Yep. The FNA and the tonsil biopsy both come back as squamous cell carcinoma, and the pathologist reports it's P16 positive, noting that strong diffuse staining that we look for.
So the file lands on your desk, the attending asks, what's the stage? What's the treatment?
Yeah.
And what's the prognosis? So you're in the hot seat. Give us the 60-second board script, just as an examinee would.
Examinee. This is a 52-year-old never smoker with a P16 positive left tonsillar squamous cell carcinoma. Imaging shows a 1.8 centimeter primary and an ipsilateral 3.2 centimeter level 2 node with central necrosis. PE shows no distant disease.
Good start.
Using A.J.C.C 8th edition staging for H.P.V positive oropharynx, the primary is T1 because it is 2 centimeters or smaller. The nodal stage is clinical N1 because disease is confined to ipsilateral nodes that are 6 centimeters or smaller. Importantly, extranodal extension does not change clinical end stage in H.P.V positive disease.
Key point.
This is clinical T1N1M0, which is stage 1 HPV positive oropharynx.
Perfect.
Prognosis is excellent in a never smoker with HPV positive disease. Standard definitive management is radiation-based therapy, commonly with concurrent cisplatin for node-positive disease, with treatment selection individualized at tumor board.
Good.
Key late effects include xerostomia and dysphagia, but long-term functional outcomes are often excellent in HPV positive patients.
Excellent. That was concise, and you hit the absolute most critical point. Let's talk about that for a second. You said extranodal extension, or ENE, does not change the clinical end stage here. Why is that such a classic oral board trap?
It's a trap because in almost every other head and neck cancer, ENE is like the ultimate sign of badness, right? It means the tumor has broken out of the lymph node capsule.
Right. It's a huge marker for aggressive biology. In the HPV negative system, it automatically pushes you to N3B.
Exactly. But the reason the A.J.C.C ignored it clinically for the HPV positive group is because the data showed that the favorable biology of the virus it overwhelms the negative prognostic hit from ENE. The survival is still so high that it didn't make sense to call it a higher stage. It's a biology-first decision.
That's a great way to put it, and it's a distinction we have to come back to when we talk about adjuvant therapy. But for now, let's talk about why this case is so typical now. Let's look at the epidemiology.
The numbers are just staggering. It's a true modern epidemic. For decades now, we've seen this dramatic rise in oropharynx cancer, but, and this is the key, it's driven entirely by the HPV-positive cases.
Meanwhile, the HPV-negative cases, the traditional smoking and drinking cancers, are actually going down.
They are, thanks to public health efforts. So the rule of thumb now in the U.S. is the 70% rule. Around 70% of all new oropharynx cancers are HPV associated.
And the patient demographics are like night and day.
Completely. For HPV positive, you're thinking younger patients, 40s, 50s, a huge male predominance, something like 3 or 4 to 1. And they're often never smokers or very light smokers, often with a higher socioeconomic status.
Compare that to the HPV negative group. Older, 60s and 70s, heavy history of tobacco and alcohol, and they come with a lot more medical baggage, heart disease, lung disease. They're just a much more frail population to treat.
And here's a high-yield board fact to really drive home the scale of this. There are now more men diagnosed with HPV-positive oropharynx cancer in the U.S. than there are women diagnosed with HPV-positive cervical cancer.
Wow. That really puts it in perspective. It's not just a GYN issue anymore. It's a major head and neck public health crisis.
For sure. And specifically, it's HPV-16. That's the strain that's responsible for the vast majority of these cases.
Right, which is different from cervical cancer, where HPV-18 plays a bigger role proportionally.
One last point here, though, a clinical safety net. You can never, ever assume the HPV status just based on the patient's story.
Oh, that's a great point.
Examiners love to throw you a curveball. What if that 52-year-old never smoker is actually HPV negative? Or the 65-year-old heavy smoker is HPV positive? You always have to test. You rely on the P16 pathology.
Absolutely. So to really understand the staging, we need to define the anatomy. Where exactly is the oropharynx?
It's that transition zone, right? It's behind the oral cavity, below the nasopharynx, and above the hypopharynx. Let's get really precise with the A.J.C.C boundaries, because that's what matters for staging.
Okay, so superiorly, the border is the junction of the hard and soft palate.
Right. And inferiorly, it goes down to the plane of the hyoid bone, which is basically at the level of the top of the epiglottis.
And the anterior border is what separates it from the oral cavity, which is a whole different ballgame.
It is. The key landmark there is the circumvallate papillae on the tongue. It's that V-shaped row of bumps. If a tumor crosses in front of that V, it's an oral tongue cancer, not oropharynx.
Okay, so within those borders, we have the 4 key subsites.
Right. First and most common is the palatine tonsils. This is where HPV-positive cancer loves to set up shop.
Second is the base of tongue. That's the posterior 1/3. And what's critical about that?
It's a midline structure, which means you immediately have to worry about bilateral lymphatic spread.
Exactly. Same goes for the third subsite, the soft palate and uvula. Also midline, also high risk for bilateral drainage.
And the fourth is the posterior pharyngeal wall, or PPW. The risk there is specifically for spread to the retropharyngeal nodes.
And all of this anatomy brings us to Waldeyer's ring.
Yes, the ring of lymphoid tissue, the palatine tonsils, the lingual tonsils at the base of the tongue, the adenoids. The reason HPV has such a tropism for the oropharynx is because of this lymphoid-rich tissue. It's the perfect environment for the virus to integrate and cause cancer.
Which is why you almost never see HPV-driven cancers in the non-lymphoid areas like the oral cavity or the true vocal cords.
Exactly. So with that anatomy in mind, let's quickly touch on the T4 structures, especially for the HPV negative system, because that's where the resectability question really comes into play.
Right, the difference between T4A and T4B. T4A is invasion into structures that are, well, they're considered moderately advanced but potentially resectable.
And there's a great mnemonic for the T4A structures, HTML plus mandible.
Okay, break it down.
H is for hard palate, T is for extrinsic tongue muscles, M is for medial pterygoid muscle, and L is for larynx, plus, of course, direct invasion of the mandible.
And T4B is the truly unresectable, stuff lateral, pterygoid, skull base, carotid encasement. Knowing that T4A versus T4B distinction is everything for HPV-negative patients because it tells you if surgery is even on the table.
Whereas in the HPV-positive system, they just group all of that into a single T4 category because the T stage just doesn't carry as much prognostic weight as the biology.
Okay, let's shift to lymphatic drainage.
Right.
We know it's a huge issue here. 70% of patients have positive nodes at presentation.
They do. And the first stop is usually levels 2 and 3. For a small, well-lateralized tonsil cancer, the drainage is usually just ipsilateral.
The moment that tumor crosses the midline or involves the base of tongue,
Everything changes. Base of tongue, soft palate, those midline structures immediately put the contralateral neck at high risk, even if you don't see any nodes there on imaging.
and we also have to remember the retropharyngeal nodes, especially for base of tongue and posterior pharyngeal wall tumors, they need to be included in the target volume.
Which brings us to a huge clinical decision point. When do you have to treat both sides of the neck?
The rule is, if the primary involves the base of tongue, crosses the midline at all, extends to the posterior pharyngeal wall, or if you see bilateral nodes on imaging.
You have to cover both necks, usually down to at least level 3. Failing to cover the contralateral level 2 in a base of tongue cancer is a major, major error.
It is. Okay, let's pivot from the where to the why. Let's get into the molecular biology of HPV oncogenesis. This is what explains everything.
This is the cool part. So the virus, HPV16, inserts its DNA into the host cell, and it starts producing two viral oncoproteins that hijack the whole system, E6 and E7.
Let's start with E6. What does it do?
E6 is like a guided missile for P53, the guardian of the genome. It binds to P53 and tags it for destruction. So the cell loses its ability to sense DNA damage and hit the self-destruct button, apoptosis.
The safety brake is gone, and then E7 comes in.
E7 is the accelerator. It goes after the retinoblastoma protein RB, which is another major tumor suppressor. RB's job is to hold on to a transcription factor called E2F. When E7 inactivates RB, E2F is released, and it just floods the cell with signals to grow and divide uncontrollably.
And here is the pearl that connects all this science back to the pathology report you get every day, the P16 connection.
Exactly. So the cell has this feedback loop. It senses that the RB brake has been disabled by E7, and in a desperate attempt to compensate, it dramatically overproduces another protein in that same pathway, which is P16.
So the P16 staining is basically a smoke signal. If you see a ton of P16, it's telling you that the E7 oncoprotein is active and has disabled the RB pathway.
Perfect analogy. And that's the whole basis for why we can use P16 as a surrogate for HPV status in the oropharynx.
Okay, so knowing that mechanism, let's list the 4 key reasons why these HPV-positive tumors have such a better prognosis.
Number 1, the status of P53. In HPV-positive cancer, P53 is just suppressed by E6, but the gene itself is usually normal or wild type. In HPV-negative cancer, the P53 gene is often mutated and completely broken.
So there's still some residual function that can be activated by radiation or chemo.
Exactly. Number 2, a much better immune response. The body sees these viral proteins as foreign, so you get more tumor-infiltrating lymphocytes, or TILs, attacking the cancer. It's a hot tumor.
Number 3 is just the patient factors, right? Younger, healthier, fewer comorbidities, less damage from smoking. They can just tolerate our treatments better.
For sure. And number 4, they are just exquisitely radiosensitive. You combine that preserved P53 pathway with the active immune response, and these cells just melt away with radiation.
And the survival difference is just, it's huge. Like you said before, a 20 to 25 percentage point difference in 3-year overall survival.
It is. So let's talk about the testing. The standard of care is P16 immunohistochemistry.
Right. It's fast, it's cheap, and it's very sensitive. And a positive result that lets you use the favorable staging is to find a strong, diffuse staining in at least 70% of the tumor cells.
but we have to know its limits. It's sensitive, but it's not perfectly specific. You can get P16 overexpression from other non-viral cancer pathways.
Which is why for clinical trials or weird cases, you might see them use more direct HPV testing, like PCR or ISH. The most specific test is detecting the E6/E7 mRNA because that proves the viral oncogenes are actually active.
And here is a huge clinical pearl for the boards. You cannot use P16 to stage non-oropharyngeal cancers.
Say more about that.
If you get a question about a P16 positive larynx cancer, you must stage it using the traditional HPV negative staging system. That favorable biology and the special staging are reserved only for the oropharynx.
That's a critical point. Okay, let's get to the main event, A.J.C.C. 8th edition staging. This is where you have to be precise.
Rule number 1, state the HPV status first, then pick the right system.
Let's start with HPV positive clinical staging.
The T staging is pretty simple. T1 is 2 centimeters or less, T2 is greater than 2, up to 4 centimeters, T3 is greater than 4 centimeters or extension to the epiglottis.
And T4 is just one big category that lumps all the advanced local invasion together.
Right. Now the N staging is where it gets really different. It's all about size and laterality. N0 is no nodes.
N1 is one or more ipsilateral nodes, as long as they're all 6 centimeters or smaller. N2 is for contralateral or bilateral nodes, again, all 6 centimeters or smaller. And N3 is for any node that's bigger than 6 centimeters.
And this is where we have to hammer home that critical board point again. Clinical E&E does not change the N stage in HPV-positive disease. Our case had a 3.2 centimeter node. That's N1. Even with obvious E&E on the scan, it would still be clinical N1.
And this feeds into the stage groupings, which really shows you how much biology matters. Stage 1 includes T1 or T2 primaries with N0 or N1 nodes.
Think about that. T2N1 is stage 1.
Right. A tumor up to 4 centimeters with a positive node in the neck is stage 1. In the old system, that would have been stage 3, maybe even 4A.
The fact that the A.J.C.C calls that stage 1 now is the clearest statement possible that biology is king.
It is. And just briefly on the pathologic staging, after surgery, it switches focus to the number of nodes. PN1 is 1 to 4 positive nodes, and PN2 is 5 or more. There's no PN3.
Okay, now let's immediately contrast that with the HPV negative staging system where all the old strict rules apply.
Right. T staging keeps that critical T4A resectable versus T4B unresectable distinction.
And N staging goes back to the old complicated N1, N2A, N2B unresectable distinction.
And here's the other side of the E&E coin. What happens if you have clinical E&E in an HPV negative patient?
It's an automatic upgrade to N3B. A tiny 2 centimeter node with clear E&E is N3B, which makes it stage 4B disease.
And that is the ultimate difference between the two systems. E&E is a catastrophic prognostic sign in the HPV negative world, but its impact is blunted by the favorable biology in the HPV positive world, at least for staging.
Exactly, but staging is just one part of the risk assessment. We also need to layer on the ANG risk criteria, which adds smoking history into the mix.
This came out of the big RTOG-0129 trial, and it lets us refine prognosis even further.
And the magic number you have to remember for your boards is 10 pack years. That's the cutoff.
Right, so let's walk through that risk ladder.
The absolute best group, low risk, is HPV positive and 10 pack years or less of smoking. That's our case patient. Their overall survival is over 90%. This is the group where we're studying de-escalation.
Then you have the intermediate risk group. This includes HPV-positive patients who are heavy smokers, more than 10 pack years. Their prognosis is still very good, but that smoking history knocks their survival down a peg, maybe into the 75 to 80% range.
That intermediate group also includes the rare HPV-negative patient who was a light smoker and had a less advanced T-stage.
And finally, the high-risk group. This is your classic unfavorable patient. HPV negative and more than 10 pack years of smoking. Their survival is way down, around 46%.
It's important to know that any HPV-negative patient with a T4 primary also gets lumped into that high-risk group no matter how much they smoked.
So the takeaway is smoking still matters. Even in the good HPV-positive group, a heavy smoking history is a significant negative prognostic factor.
Let's bring it all back to our case. 52-year-old never smoker, P16 positive, T1N1M0.
A.J.C.C, 8th edition for HPV positive. That's stage 1. ANG risk criteria. HPV positive and a never smoker.
Textbook low risk. We're telling him his prognosis is excellent, likely over 90%.
Now, for just a second, what if that exact same anatomy T1, 3.2 centimeter node, was P16 negative in a 40 pack year smoker?
Whole different story. The primary is still T1, but the 3.2 centimeter node is now N2A, so that's stage 3. And if it had clinical E&E, it would be N3B stage 4B.
And his ANG risk?
HPV negative and 40 pack years. He's squarely in the high-risk group. We're talking about a survival around 46%, same anatomy, radically different outcomes.
Wow. Okay, let's cover a few common traps before we get to the board questions.
Trap 1 is just mixing up the staging systems. You have to be militant about this. If the patient is P16 negative, you must use the HPV negative rules. If you call an E&E positive node N1 in that patient, you've failed the question. That is N3B.
Trap 2 is assuming the demographics tell the story. The young, healthy patient is usually HPV positive, but you have to prove it with the P16 test. Always test.
And trap 3 is the most subtle. It's about E&E in the HPV positive patient. We said it doesn't change the clinical stage, so why do we still care about it?
We care about it because if that patient has surgery and the pathology report comes back with E&E, it becomes a major driver for adjuvant therapy. It's a high-risk feature that tells you that patient needs chemoradiation after surgery, not just radiation alone.
That is a critical distinction. Staging is for prognosis. Pathologic risk factors like E&E or positive margins are for deciding treatment intensity. Two separate things.
Exactly. So looking to the future, we're moving beyond even this. We're looking at things that are not yet standard of care, but you need to know about.
Right. Three big areas. First, circulating tumor DNA, or ctDNA.
This is so exciting. We're looking for fragments of tumor DNA in the blood. And what studies are showing is that if we can still detect ctDNA after treatment is finished, it can predict a recurrence months before anything shows up on a PT scan.
It could totally change how we do surveillance. The second area is radiomics. This is basically using AI to analyze the texture and patterns of a tumor on a CT or MRI scan.
And the hope is that we can find a signature that predicts which tumors will respond well to radiation and which won't, so we can tailor treatment up front.
And third is digging deeper into the tumor microenvironment, looking at the number of TILs, PD-L1 expression.
Yeah, trying to figure out which HPV-positive patients have a really hot immune response and might be candidates for de-escalation, and which have a cold tumor and might need more aggressive therapy.
None of this is ready for prime time yet, but it's where the field is heading.
For sure. Okay, let's lock in this knowledge. Board review blitz, 4 questions.
Question 1. A 58-year-old man, 30-pack-year smoker, has a P16 positive tonsil cancer. The primary is 3 centimeters. He has 3 ipsilateral level 2 nodes. The largest is 4 centimeters. What is his clinical stage? Is it A, stage 1, B, stage 2, C, stage 3, or D, stage 4A?
The answer is A, stage 1.
And the rationale.
He's HPV positive, so we use that system. A 3-centimeter primary is T2. Multiple ipsilateral nodes, all under 6 centimeters, is N1. T2, N1, N0 is stage 1 in the HPV positive system. The smoking history puts him in the intermediate risk ANG category for prognosis, but it does not change his A.J.C.C stage.
Perfect. Question 2. A 65-year-old never smoker has a P16 negative base of tongue cancer. Primary is 2.5 centimeters. She has a single ipsilateral LEP2 node that's 3.5 centimeters, and the scan suggests E&E. What is her end stage? Is it A, N1, B, N2A, C, N2B, or D, N3B?
The answer is D, N3B.
Why?
Because she's HPV negative. And in the HPV negative system, clinical E&E automatically upgrades you to N3B, no matter how small the node is.
Yeah.
That E&E finding is the trump card.
Excellent. Question 3. Which of the following is true about P16 testing? A, P16 positivity in the oral cavity means better prognosis. B, P16 IHC is more specific than HPV DNA testing. C, P16 positivity in the oropharynx is an acceptable surrogate for HPV status. Or D, P16 should replace all other HPV testing.
The answer is C. P16 positivity in the oropharynx is an acceptable surrogate.
Rationale.
That's the entire basis for the separate staging system. It's only been validated as a reliable prognostic marker in the oropharynx. P16 positivity in the larynx or oral cavity does not carry that same favorable biology. Last one, question 4. Which patient cohort is designated high risk according to the ANG criteria? A, HPV positive with more than 10 pack years. B, HPV positive with N2B disease. C, HPV negative with more than 10 pack years. Or D, HPV positive with a T4 primary.
The correct answer here is C, HPV negative with more than 10 pack years of smoking.
And that's because the ANG high-risk category is defined by the unfavorable HPV negative biology, either combined with heavy smoking or a very advanced primary tumor.
Exactly. Okay, let's wrap this up with our 5 high-yield clinical pearls.
Let's do it.
Pearl number 1. HPV-positive oropharynx is a distinct disease entity with dramatically better prognosis than HPV-negative disease.
And the context here is just how big that difference is.
Yeah.
You need to remember it's a 20 to 25 percentage point difference in overall survival. It's a chasm, not a small gap.
Pearl number 2. A.J.C.C. 8th edition has separate staging systems for HPV positive and HPV negative oropharynx. Use the correct system.
The context is that T2N1 test. Remember that T2N1 used to be advanced stage disease. Now, for HPV-positive patients, T2N1M0 is stage 1, biology over bulk.
Pearl number 3. Extranodal extension does not affect end staging in HPV-positive clinical staging, but it does affect adjuvant therapy decisions after surgery.
And the context is separating prognosis from treatment decisions. E&E is ignored for the initial stage grouping, but if it's found in a surgical specimen, it's a major red flag that tells you to intensify adjuvant treatment.
Pearl number 4. P16 immunohistochemistry is an acceptable surrogate for HPV status in the oropharynx, but do not use it to HPV stage non-oropharyngeal sites.
Context. Just remember that P16 can be overexpressed for lots of reasons in cancer, but the specific HPV-driven biology that gives that huge survival benefit is only reliably linked to P16 in the oropharynx.
And pearl number 5. Smoking modifies prognosis even in HPV-positive patients. The ANG criteria use 10 pack years as the threshold.
The context there is that you can't get complacent. Even in the favorable HPV-positive group, a heavy smoking history is a real negative prognostic factor that pushes a patient into a higher risk category.
This has been a really deep but necessary review of the foundations of oropharynx cancer.
Absolutely. Let's do a quick recap of the main pillars.
First, the dual nature of the disease, driven by the HPV epidemic.
Second, the E6-E7 mechanism. E6 kills P53, E7 disables RB, and that leads to the P16 smoke signal.
Third, the anatomy. Know the boundaries, the T4 structures, and when you have to cover the bilateral neck, especially for base of tongue.
And fourth, mastering the staging differences, especially the role of E&E, how it's a game changer for HPV-negative staging, but ignored for HPV-positive clinical staging, and then layering on the ANG criteria.
That really covers the fundamentals. So let's end with a final provocative thought for you to consider.
Go for it.
Given the cost and the radiation exposure of PE scans and the fact that these patients are long-term survivors, will dtDNA eventually replace post-treatment PET scans altogether? Will we get to a point where we're monitoring for microscopic recurrence with a blood test before it ever becomes visible on a scan?
That shift from anatomical to molecular surveillance is absolutely the next frontier. It's what will define the care for these patients over the next decade.
It will indeed, and that brings us to the end of this foundational review. Next time, we will dive into the evidence for definitive chemoradiation. We'll talk about why cisplatin is still king, what happened with cetuximab, and how to manage platinum-intolerant patients.
You can complete practiced oral boards and access more resources at radonsmartlearn.com. Thanks for tuning in to the Rad on Smart Review.